All right. All right. So I've got about 170 slides here, so it should be only 2 or 3 hours minimum. So no worries. So hi, my name is Ben Aga from Mayo Clinic. I'm here today to talk about our proton beam therapy facility and also some of the collaboration work that we did with NCSA to kind of make this whole thing happen. So I'm going to maybe diverge a little bit here. I want to talk a little bit about kind of cancer treatment through history, kind of how it's evolved in that time. Kind of the whole point of cancer treatment has really been, how do I kill the cancer without killing the patient with it? And it's been an ongoing battle for really thousands of years. Surgery is kind of the tried and true old school method. It's been around forever. Basically, I see a tumor, can I cut it out? Can I get rid of this right now? It kind of works, kind of doesn't. If you have a hard time getting close to a critical issue, if you're next to an optic nerve, you can't cut out a tumor. You can't get all the tumor sometimes, so this doesn't always work that well. Another option is chemotherapy. It was kind of found about during World War I that a lot of the horrible agents, mustard gases, et cetera, were kind of killing some cells more than other cells, and the thought was, hey, can we apply this for a good thing? Can we use this for chemotherapy? And some great minds came along and found a lot of different drugs that could actually be used to cure some cancers. Downside of chemotherapy, it's a relatively blunt instrument. It makes you very sick, so there's a lot of cancers that don't respond to it as well either. So that's another tool in the arsenal, but doesn't do everything either. Another thing, kind of a newer trend here, is kind of the vaccine and the genomic approach. Very targeted approaches that really do great things stopping cancer in their tracks. You can take a pill for a few cancers and they're done for life. Downside is it's very targeted and very immature right now. Only a few select cancer types respond to this type of treatment. This work is ongoing in the genomic space. I think in the next 10, 15 years, this will multiply a little bit and get more cancers treated in this way, but for now it's a very niche application of treatment. And the last thing here is one of the old school methods as well, which is radiation. Radiation is very good at killing things. Basically, you send a blast of particles at something, you hit the electrons, you ionize, and you kill a cell. And it's good for killing cancer and healthy tissue around it. So it was kind of a tough thing, is how do we make x-rays kind of work and actually kill cancer? They were known about for 100 years to do this, but only the last kind of 30 to 40 was kind of the technology in place to actually allow x-rays to work well in that setting. And I guess kind of the son of x-rays, I would say, is proton therapy, where it's kind of the same idea. It's radiation, but a different type of particle, a different way of doing things that has kind of a better theoretical way to do radiation treatment than x-rays. And I'm going to go into more detail on that in a few minutes here. And kind of the gist of this slide is different cancers, different setups require different treatments. So let's dig into proton therapy. Kind of, how does it work? It's like X-ray radiation, but it's a different particle. X-ray radiation are photons, massless little light particles, high energy, that are basically hitting tumors, hitting electrons, and ionizing and destroying them. Protons do about the same thing. Figure this out. There we go, okay. However, they act a little bit differently. So pick up here, picture this is basically somebody's body. And over here is the skin where you're going to start hitting this person with x-rays or protons. What happens is how x-rays behave, they dump a massive amount of radiation right when they hit your skin the first time, and the tumor's way back here. So it gets some radiation, but there's a big spot here that gets a lot of radiation you don't really want it to be at. It also tails off and you get some radiation behind your tumor as well. There's a quirky effect of protons called the Bragg effect that basically means that you can tune a proton. You can give it enough energy that it goes to a specific depth and only that depth. So it's great for basically avoiding tissue you don't want to irradiate. So it's targeted x-rays to kind of a certain extent. So it can potentially have very precise treatment, much less insular damage than x-rays would give you. A few other differences too, x-rays are pretty tried and true, pretty simple. You can get your x-rays done in your dentist office, wherever, it's no big deal. Protons are a little bit bigger deal. You need a particle accelerator. Heavy iron, big deal here. This is not going to be in your dentist office. If your dentist has one of these, I'd probably find a new one. Okay. So I kind of touched on this a little bit, but so proton therapy, good God, you need an accelerator. What are the benefits to make this capital outlay useful? Well, it really enables aggressive treatment. Say you've got a brain tumor next to your optic nerve. What are my options? Okay, I'll do surgery. Well, you have a choice. Do you want to be really aggressive? We may take your optic nerve out, but it'll get rid of the tumor. You want to be conservative? We'll save your eyesight, but we might miss some of the tumor. And same with radiation, with x-rays. We can get most of the tumor and save your eye, or maybe we'll go ahead and take the tumor and hit the nerve. So there's oftentimes a lot of trade-offs between killing the tumor and saving tissue. Proton therapy allows you to be much more aggressive and kill more tumor and less of the good tissue around it. Example here on the left here, the left side here is proton therapy for a tumor in the center of a mass. Right side is x-ray. You can see, again, the protons, you come in and stop right there. So you have a relatively benign amount of radiation outside the tumor. So you have two beams coming both sides. X-rays, it's kind of a shotgun approach, really. You have beams coming in from several directions, a lot of radiation in places you don't want it to be. So really, you can't be as aggressive. You can't treat as many tricky locations. And another kind of really pernicious effect, downside of radiation treatment in general is, say at age 30, you came to the doctor and you had a tumor. You had a great oncologist who took care of it. At 31, you're cancer-free. Awesome. What happens at maybe 46, 48, you come back to the doctor, you have cancer again. A lot of times, the actual radiation that cured this cancer causes a different type of cancer later on in your life. So it's a trade-off. All that extra cancer kind of ups the ante for having a later bout of cancer in your life as well. So anything we can do to reduce all that extra radiation in your body is a bonus for avoiding secondary cancers. And a huge benefit of this is for childhood cancers. You have a long life ahead of you. It's very good not to have extra radiation as a child is 7 years old for cancer treatment. Excuse me. And another nice thing too is less side effects. Big side effect of radiation treatment with x-rays is nausea, diarrhea. It's not a very pleasant experience. Proton therapy lessens that as well. And just another shot of kind of the targeted selection here. Again, we have a tumor here, x-ray beam blasting through, a lot of radiation on the front side here and some leaking to the back. Protons here, pretty tight gradient. Not much radiation, but we're really hitting that tumor quite hard. Okay, so where can you get this done? So there are currently 14 proton treatment facilities in the US right now and 11 new ones under construction. So it's a pretty fast moving field here. A lot of activity in this space, a lot of people building these out. 2 of these under construction are under Mayo Clinic. One is being built in Rochester, Minnesota. That will open basically next month, so it's imminent to be opening. And we have a Phoenix campus as well. That proton beam facility will open next year. Here's a couple shots of the facility in Rochester under construction here. That big giant hole there is for the particle accelerator. So kind of big deal here to house that sucker. It was down in the basement. Next up here, next stage of the construction, those 4 little kind of kidney shapes, those are individual treatment rooms for each patient. We had an opportunity to do a tour of those, and it's kind of cool. You walk in this little room, and it's a little patient table, and then kind of like a ray gun called a gantry, basically shooting proton beams. Relatively modest sized room, maybe 20 feet by 20 feet, a 10-foot ceiling. And then you walk behind this little door to the back side, and you walk out into this catwalk, and you look down about 20 feet, and you look up like 20 feet, and it's this huge expanse. It's like a James Bond villain lair. It's full of equipment and giant magnets and electrical stuff and cooling. It's a massive engineering undertaking. And to think about it, this whole building, this giant footprint is here to serve 1, 2, 3, 4 patients at a time. So it's a pretty massive undertaking for the work it's doing. Again, here's a little bit further on. This is the concrete pour going on. I guess a nerd fun fact. This is supposedly one of the largest continuous concrete pours in Minnesota history. Apparently they put a lot of concrete in this building. 1, heavy stuff, and 2, neutron flux from the radiation. So a lot of concrete in this building. So if there's a tornado in Rochester, head to the Proton facility. You'd be good to go. All right, so a few more details on the facility. Like I said, both Rochester and Arizona each will have 4 treatment rooms running at full speed. Probably about 140 patients per day is the slated thought of people will have in there. Some of the technology we're going to be deploying, something called pencil beam scanning. Basically, we're continually refining the size of the proton beam being shot at the tumor to basically give better coverage and also avoid hitting basically good tissue. Here's an example of how you would pencil scan with the old, or excuse me, you'd scan with the old non-pencil scan It does a pretty good job, but you have a lot of leakage here. You notice we're hitting a normal organ here. The new algorithm we're working with has a much smaller spot size. So you can see we're missing that tumor and having good coverage here as well. So again, just a basically nicer new technology to get better coverage and less of those secondary radiation, which we want to avoid at all costs. Potential uses, a lot of cancers. I think the big ones initially are going to be head and neck tumors, lung cancer, and prostate cancer, and also a lot of childhood cancers for the secondary reasons I mentioned before. And also some kind of, I guess, soft benefits or other things we're doing with this facility is kind of collaborating with other people in this space to look at best practices. What cancers respond well, what doesn't work well, and also efficacy testing. It's kind of a interesting thing about proton beam. You know, common sense wise, theoretically, this has got to be great, right? I mean, it's got to be much more efficient, much more efficacy. There have not been a lot of peer-reviewed studies yet to say how much better proton beam therapy is compared to vanilla X-ray therapy. So a lot of the work out of the facility is going to basically kind of do those studies and say, cancer ABCD is great, WYXZ, don't please use for those. It's shown to be no better than X-rays in that case. So some of that data is going to come out of the facility as it comes online as well. So how is the dose determined? You know, you come into the facility and what happens? Well, first the patient gets an MRI and a CT scan performed, and that is basically turned into a voxel mesh. You have, you know, say it was a head scan. I've got my regular tissue head scan plus my tumor all in this voxel mesh. And then a treatment plan is created. And what's a treatment plan? That's basically how do we slice and dice the proton energies to treat your cancer. A lot of levers you can use. The main levers at at Mayo Clinic are proton energy, proton beam width, so how many protons am I shooting at a time, and lastly, how am I placing the beams? What's the best way to basically avoid tissue and get in the right spot? At the right here, you can kind of see, as a dosimetrist, what you would see treating a patient. This is all stuff I have no idea what's going on, way over my head. But on the right side, it kind of gives a good shot of what the tumor actually is and how it's kind of numerically or situated or created. This is actually a 3D model of a tumor, looking at edge on, and this is one of the slices of that tumor. Basically, as you can see, the beam is painting across back and forth. And so you vary those energy levels, you do a slice, vary, energy slice, vary, energy slice, and basically walk through the entire volume of that tumor to basically paint the whole thing with protons. And there is vended software for treatment planning available and in use right now. Again, as I mentioned, X-rays have been around for 30 plus years in the clinical setting, so a lot of vendors are in place to support X-rays. They're slowly moving to proton therapy. So the software is okay now, but we're kind of thinking we can do much better in-house. A lot of limitations in that software, and that's kind of where Mayo's development plus the NCSA collaboration kind of comes in here. So I'll walk through a few of the limitations, kind of a gripe list here. The FDA requires that every treatment plan has a second check, which is basically a sanity check, validation, verification of, is this treatment plan actually correct? And the second check in use right now from the vendors is, we're not very happy with it. A lot of assumptions are made. Generally, when a proton interacts with matter, it's a statistical happening. You can't have an analytical approach to it. You got to do a lot of basically runs to get a good idea how that proton is going to interact through bone, blood, brain, tumor. That's not being done right now. Basically, a best guess analytical approach is being done by some of the vendors right now. Also, there's a greatly simplified physical model. Instead of using bone, blood, brain, it's basically a bunch of different waters with swag densities. So it's kind of a hack, really, to basically account for the different materials inside of a control volume. And the proton material interactions are greatly simplified as well. Some of the higher order stuff in the electron cloud is not taken into account either. Also, there is optimization. So one of the big things we want to do is optimize the treatment plan. How can I vary some things to find a best treatment plan? It's there, but again, it's based upon this analytical approach, so it's kind of not super useful. So what's our challenge? Like I said, the things we want are not commercially available right now, so I guess we're going to have to make it ourselves. The big thing we wanted was a Monte Carlo-based second check to basically validate our treatment planning. And Monte Carlo-based particle tracking is pretty common in industry, or not in industry, excuse me, in academia. Basically, it takes a statistical distribution of how a particle might interact with point A, point B, point C through point a billion as it runs through model. You get basically a best path statistically. So it gives you a very good idea of how that path is going to basically pan out for that particle. And also you want to do robust optimization. And again, robust optimization is just a fancy way of saying optimization with uncertainty of your inputs. So you want to basically enable that as well too. And we have two kind of dueling banjo type development efforts going on right now at Mayo. We have one group that is kind of heavy iron, old school, C++ MPI based optimization code, and one a little more novel, which is a GPU CUDA based setup right now. They both do about the same thing. In the interest of time and your guys' sanity, I'm going to go ahead and just work with the CUDA based thing for the rest of this presentation, but bear in mind it's roughly the same physics and math behind the scenes. RO, robust optimization, is pretty computationally intense. You know, on the order of hundreds of cores, dozens of GPUs, and that's kind of mainstream. That's nothing mind-blowing there. The issue for us, though, is that remember those 140 patients a day? We have a huge amount of patient volume coming through that need these treatment plans, and it's people getting treatment. So we have a lot of pressure to basically make sure these treatment plans are done quickly and on time. So it's really not a huge problem per se, but it's a lot of medium-sized problems, and a turnaround time is our issue right now. Okay. So I'm going to kind of dig into the details of the second check-in optimization here, and I did not think of that name. I'm not sure what wild person did. I'm not taking any credit for that, and Mr. Spock is not very happy either, I think, with that choice. Again, this is Monte Carlo based, so we have statistical tracking of the tools. Rough swag of what we're looking at here for a domain. Typical particle proton beam therapy, a single beam, may have about 10 to the 10th potential particle interactions along its path. If we model about 10 to the 7th of those, so about 1 in 10,000, we get our confidence interval up to 99%. So that's kind of at the heart of a Monte Carlo what it does. That's kind of our details that we can do about that much of the actual path for that much confidence interval. And then it is, for the physicists out there, it's basically Giant functionality just written in CUDA. So we took a subset, the same idea how that particle tracking works, and it was written into CUDA. All right, next up is the robust optimization code. And this is, God, I'm embarrassed to even show this. This is even a worse acronym. So anyway, I think Dr. McCoy is not digging this either. Big thing here is the second check is the computational kernel, so we're kind of using that as basically the driver as the function being evaluated inside the RO. So all the RO is basically an optimization wrapped around the second check calculation. Some basic hits on the optimization. It's just a old school gradient optimizer. The big control variables we're using is proton energy, varying from about 70 up to 230 million electron volts. The beam width again, or the beam density, is from 1,000 to 10,000 protons per beam. And then kind of how do I position the beam? And this can vary a lot based upon whether it's prostate, head and neck cancers. Example of a head and neck cancer, you might cover maybe roughly a third of a sphere, kind of around somebody's head, would might be a general usual kind of domain for that control variable. And usually we're talking several million permutations is kind of a rough kind of idea of the domain space of this right now. And the objective function is basically kind of a dual cost function. One, we want to just maximize the amount of radiation hitting the tumor while also minimizing the amount hitting outside of that. And that's basically just quantified into a cost function. All right. So a lot of cool stuff. Well, what do we need NCSA for? Well, it turns out a lot. Mayo's in-house research cluster is very heavily informatics focused. And one of the dirty little secrets of informatics is it doesn't like MPI. It doesn't even know what MPI is. It's shared memory at best, a lot of single-threaded stuff. So there was not an in-house InfiniBand environment to handle that code I talked about. Remember way back in the presentation I talked about that MPI code one of the researchers had? He wanted to run that at Mayo. He couldn't because we had no environment for him. So called Evan into panic, said, hey, we need your help. Can we use iForge? You have InfiniBand. And basically, as a stopgap, we were able to run some of his initial runs on iForge as we scrambled with our vendor, hardware vendor, to basically get our own IB environment in place, went ahead and slapped that in place and used iForge as, at that point, as a sanity check and a vetting ground and a launch pad, basically to make sure we had a good environment. So it was a great, set for us to basically feel comfortable with our own environment, that we didn't have to jump in the deep end. We knew kind of what was happening, and we could basically vet our code in our environment with iForge, which we knew was a good environment to work with. So that was for the CPU side. On the GPU side, it was even more challenging. We have no GPUs, and to be frank, not a lot of other people asking for GPUs at this point. So it's kind of like, oh God, you guys want how many GPUs? So we could basically give them a few, and they'd kind of have a so-so workflow with it. Or we could buy all the GPUs they wanted, and maybe have a boat anchor in the data center. So what do we do? Well, NCSA to the rescue again. What about Blue Waters? That's got a lot of GPUs, right? So again, bothered Evan again, another panic call to Evan. And go ahead and set us up with a PSP allocation onto Blue Waters. And it was great for us, just one from a monetary point of view. We went from this giant CapEx that might pan out, might not, into a pretty modest operating expense, so we could basically pay for play and use all the GPUs we wanted. So it was a great spot for scaling out, and also a great spot for really being low risk to us. We kind of passed that risk on to the Blue Waters folks at NSF. They have the hardware in place, so we're just basically renting it as we need it. And more than that, more than the money side, we had a lot of great help. Luda was in there a little bit earlier to give us some great scheduling, tuning help. So a lot of great help from the support staff as well too. And lastly here, HPC work CUDA programming. So this code kind of grew up on kind of somebody's dream, and it kind of grew up as a desktop-enabled CUDA programming setup. So it was not a lot of thought of HPC initially, not a lot of thought initially of how we're going to scale this out, use GPU Direct, use RDMA type technologies. So what happens was this code was built running fine on a desktop and not scaling well at all when it went to basically size. And that was basically just due to some choices made during the early development phases here. So kind of talked to Evan and Ahmed about, hey, can we go ahead and get some profiling going in this code? What are the bottlenecks right now? And also, if need be, do we need to rebuild this from the ground up? Do we do some minor tweaks? What's happening with that? And that effort is ongoing right now. So right now, actually next week, we're having another meeting with Ahmed's team to figure out kind of what are some kind of Band-Aid options with pluses we can do for that, and what are some basically major options we can do, and how can we basically profile this code and improve it to improve our run times. And the code works as is, but the big thing is we have a pretty large requirement for GPUs, and the hope I have for this from NCSA's help is that either you can get us by with less GPUs and save us some money, or we can use the current GPU path to improve the optimization or the turnaround time. So basically just a way to improve the functionality, and we can choose to turn the dial to faster turnaround or to more domain coverage. Okay, so what are we doing next? So kind of wrap up here, this is kind of a scattershot technology presentation, so I'll try to bring it home and make some sense of it. So when we open the Rochester facility in about a month's time, the vended application from the vendor, warts and all, is still acceptable. I shouldn't bag on it too much. It's a good tool, just it could be better. Working as is, we're going to use the vended application will be our initial treatment planning tool. However, both the GPU and CPU developed second check tool, which again, the second check is a Monte Carlo based tracking tool. Those will be used for plan validation. Basically, we're going to use those two to validate the treatment plan from the vendor and to cross-validate each other. And this is relatively modest. These run in a couple minutes on a single server. So this is a pretty modest computational burden here. However, the big enchilada here is the RO stuff, is the optimization, which is going to take the HPC resources. This is still under development. The final development environment, I think, is going to be determined once we get some of the information from Ahmed's team to say X GPUs, X CPUs, this is a good spot to run this at. So that's still be determined. Going to be a lot of NCSA help to basically help us figure that out. And then lastly, the idea is to use the RO initially for kind of those tough treatments where we're really close to hitting a vital organ. Can we go ahead and use the RO to find the optimum treatment path to treat the really tricky cancers? And then longer term to roll it out and basically do all treatment planning with the robust optimization to basically give everybody the best treatment and the less extra radiation that we can. Okay, so that's it. Q&As now, just caveats here. I'm none of these things, so your mileage is really going to vary. Ask me questions. So any Questions, comments, concerns? I'm gonna wait for a mic maybe.
I have a very loud voice.
All right, question. It would appear to me that your second check is probably more sophisticated than the primary patient treatment plan. Mm-hmm. Would that be a fair statement? And can you use the second check as a treatment plan?
I think potentially, and again, I'm speculating here. My guess is there's some FDA regulations that it's going to need some vetting and some work through to basically make that the primary setup. But I think you are correct that it's probably a better tool. It just has not been vetted in the industry yet.
I would feel more confident with your second check, given what you've done with the software.
Well, yeah, I just had a lot of we's here. I did not develop this either. So I'm one of the IT drones at Mayo here, basically making this happen too. So don't thank me, thank the awesome physicists at Mayo, basically making this happen. So.
In practical terms, are you going to have to build? Are you going? Don't hold the button. Oh, okay. Give it a second. Sorry. Are you going to have to build a data center to go with the proton beam facility to actually implement the methods?
Like I said, it's not that bad. You know, like I said, we're not modeling supernovas here. It's not cutting edge HPC. It's kind of turn the crank HPC, but it's still pretty big for Mayo's point of view. I mean, to run, like I said, to run the second check, it's only a server. It's not a big deal, but to run, say, a full-on RO, probably at least a couple racks. So it's modest. It's not a big deal. Not a big deal. Basically, the issue we have is vetting this out and expanding this because we're making some assumptions that the RO is looking at 3 variables with that much granularity. The question is, what's our trade-off cost versus how much of the domain we want to cover? And that, I think.
Yeah, well, I assume that compared to the total cost of the facility, this is peanuts.
Oh, it's negligible, yeah. Yeah, exactly.
Yeah, and
That's
you
true.
probably put a few servers with each patient treatment room. And
yeah, I want you to talk to our physicists and tell them that.
Okay.
Any other? Oh, sorry. Oh, go ahead.
Good. All right. So how do you do the validation then? Do you actually have some sort of sensing when it's going into the patient?
I know one of the validation tests is there is like I think it's nightly. There is a nightly calibration of the actual beam done on like a blank water volume. That's like a basically symmetric. I think it's just a cube of water that's basically symmetric. So you basically do a sensor validation and a treatment plan verification on kind of that reference volume.
Okay, but do you actually verify on patients as well?
I don't know. I'm sure there is a way that's done. I'm trying to think how they would do that because there's a lot of variability patient to patient is the issue. So I don't know. Good question. I don't know. I'll thought of my caveats for that one. Sure. Go ahead.
Roughly speaking, how often does the second check question or contradict the primary treatment plan?
I have no idea. It's a good question. So hopefully not often, but I'm sure it does. It's there for a reason. So. All right, last chance. All right, thank you very much. Appreciate it.